So yeah, how to diagnose painful disc, I think is where you said, and then regenerative techniques or
Yes,
technologies.
yes.
Um, so I'll start with what we learned from some of the research my team published 10 years ago. And a couple things can predict whether a patient has a painful disc versus a painful facet joint, let's say. And age plays a role. The younger the patient, the more likely they are to have a painful disc. Um, the mean age of folks who have painful disc is 40, 42, 43, whereas the mean age of folks who have a painful joint is closer to 60. Um, and there's a couple things we can do in the clinic with exam, although physical exam is really not a crystal ball. Um, Imaging can help somewhat. Looking at an MRI, there's a couple of things on an MRI that you and I might look for that might increase the odds that that disc is painful if we were to stimulate it, and that would be high intensity zones and modic end plate changes. Um, and then lastly, I suppose, would be discography, which is contentious because it's a provocative test, and the physician really has to make sure they're using strict criteria to minimize false positives. I can share my screen and show a picture, but really what we're trying to do is determine if a disc has a painful tear in it. And that's what is a marker, or the marker of a painful disc that brings patients in to see you and I, right? So if you want, I can do that real quick.
Yeah, let's do that.
All right, so you see a PowerPoint slide,
Yep,
hopefully.
I
So
see.
here, yeah,
Yeah, I got it. I see it.
okay. So on the left is an MRI, and it's really tough. I mean, there's some mild loss of water content here, maybe a protrusion back here, but it's hard to know that disc is really hurting. But after we inject contrast into it, that's the white stuff here you and I recognize readily. And then the red box is drawing our attention to the dye is in the backside of the disc, and that's not normal. That's indicative of a tear. And in this case, that tear is what caused the patient's low back pain. So, this is frankly almost the easy part, because treating this painful disc is really the challenge. And that's what has really consumed numerous efforts and time, energy, and capital over the past couple of decades to develop something to treat these painful discs.
I tell my patients that there is no good treatment for this problem, but we do have lots of bad ones.
Yeah.
And then we go into the litany of bad treatments. And, over the years, there's been IDET, where we burn the inside of the disc. As you know, I like to stick steroids in there. There's other lesioning procedures. There is fusion surgery. There's disc replacement surgery. But what would be ideal would be to put in a medicine to regenerate the disc and rehabilitate the disc. And frankly, that's not readily available, but that's what I want to talk to you about today. So I want to push the discussion to that area.
Yeah, you hit the nail on the head, right, Brad? We don't have a home run for treating these painful discs, and that maybe reflects the complexity of a painful disc. There's biochemical things that are not right. There's biomechanical deficiencies of a painful disc, and so addressing both of those simultaneously in this structure that doesn't have great blood supply is a challenge. It's a harsh environment in the disc, low oxygen tension, relatively high acidity, and then blood can't get to it readily to let the body heal. Um, so the idea of putting a medicine or something into the disc to stimulate healing is very attractive and somewhat elusive. We've both been involved in clinical research studies probably over the past 18 years.
Right.
And to share another anecdote, I saw a patient within the past 2 years who I hadn't seen in 10 years, but she was a patient we enrolled in the growth factor study, the Stryker Biotech growth factor study back in 2006, 2007. And she did all right. But then she reappeared 10 years later and she said, Dr. DePalma, I came back to see you because while I got maybe some relief back then and I'm still hurting, I just wondered after 10 years if something has been developed that's now, legitimately an option. And I had to explain to her, no, we don't. We're not really much further along than we were 10. But that just made me pause and kind of reminded me, we're busy working, seeing patients day in, day out, that we haven't moved the needle a whole lot, specifically on painful disc, right?
Right. Which is incredibly common,
Yeah,
especially in the 25 to 55-year-old age group.
right, right. And that's the swath of folks who are trying to be productive. They have to be productive during those decades. So I mentioned growth factors. That's been one technology that's been explored. A couple different clinical trials that were started and completed 12, 14 years ago. And there does not appear to be evidence that standalone growth factors are effective, at least the recombinant type. Um, and I can kind of keep going along this pathway if you want me to, or you can help me with
Okay,
questions.
well, I guess bring us up to current. I mean, you and I have looked at we did a fibrin blue study. We've done mesoblast. Bring us up to the present day. And I know even in June, the FDA, really started maybe enforcing certain guidelines. So part of the problem, Mike, is not only getting these substances in our hands, but also being able to utilize them. Because, for instance, you could take stem cells from me, you could take them out of my hip or my back, but you're not allowed to grow them um, and create my own product. So you may not get enough, as an example. So can you tell us a little bit about the guidelines and what's going on with the government and things like that?
I can try. So yeah, bone marrow aspirate was one example. Another one would be pulling out peripheral blood and spinning it down and injecting some of the growth factors from peripheral blood into a painful disc. Those are two procedures I don't do in my office currently. Um, but you touched upon a point that's worth mentioning, that the FDA has kind of reiterated their position beginning of June, just almost 2 months ago, that those even though it's the patient's own tissue, um, the way the tissue is handled and harvested and minimally manipulated must be compliant with that exact definition to remain compliant with that to be used and offered to a patient. And the FDA, I think, is trying to crack down on that a little bit. In terms of guidelines, there are various different guidelines, and there actually was a consensus or a Delphi panel that I was involved in that was just published maybe 14 months ago, where there was consensus among experts on how to handle uh, PRP or BMAC, tissue from the patient responsibly, adhering to certain agreed upon principles, informed consent, using IRB, certain novel applications, things like that. So I think there's a reason to be judicious here, because there are some things going on that are not maybe safe. I mean, taking tissue not from the patient, from elsewhere, like a tissue amniotic fluid bank or something, and promoting it as containing cells and then injecting it indiscriminately into patients, that might not be the best way to do that. But so there needs to be some caution, I think.
Are you currently using any products? I'll bring up Viadisc as an example.
Yeah.
Are you using any products, and if so, what are you using, and tell us about it, and if not, tell us about that.
Well, so I mentioned I'm not injecting BMAC or PRP, and at the moment not using any products. So Viadisc is Vivex has a tissue disc tissue allograft that was studied in a randomized controlled trial. We were a site in that study. Um, that product is not at the moment commercially available. Kind of on the heels of that FDA statement I just mentioned, it might something similar might become available after the end of the summer. But I haven't used that. We, as I said, participated in the study and injected patients who enrolled in the study. Um, your question was twofold. Products I am using, if not, why not, or what not, or what are we doing?
Well, it doesn't sound like you're really using any products unless they're part of a research trial at this time. Is that right?
Correct. Yep.
That's what I try to do. I try to get in a research trial so I have access to them.
Exactly.
But right now, I don't have any regenerative back trials that we're enrolling in. Do you?
No. Vivex, so it was Mesoblast, Dysgenics, Vivex, or Vidisc were the last batch, so to speak.
Yeah.
Mesoblast was in there, their phase 3 was in there as well. So no, now they're as you know, the way product or way drug or development works, there will have to be larger phase 3 studies, and those might be coming down the pipeline at some point, but they're not here right now.
I'm going to shift gears a little bit, and I find the rehab for these folks very frustrating as well. But I'm curious about how that fits in with, obviously it's very physiatric to get people in physical therapy, do spine stabilization exercises, but maybe we should mention, hey, the exercises that one should do for this problem, or what they should avoid. So what are your thoughts on that?
Yeah, I try to start the conversation with our patients, to plant the seed that physical therapy is important, but from a biomechanics standpoint, not, everybody kind of knows what core stabilization, I mean, that means something to, everybody can recognize that phrase, but what does it mean exactly? But I think part of that passing of information to the patients involves teaching them things to maybe avoid or ways to do things to minimize strain on their back. For example, when we lean into the mirror to shave or brush our teeth in the morning, I'll stretch my arm out. So I'm leaning through my arm into the countertop so my body weight is not supported through my low back. And as I've gotten older, I found that I have to do these little tricks to minimize back discomfort. So that absolutely, just counseling folks on getting up out of a chair. Don't lean forward as much. Slide your rear end to the edge of the chair, then sit or then stand straight up. But yeah, these are things that tips we should pass along to patients. It's important to minimize strain on the low back.
Absolutely. And there are certain postures that actually will have been shown to increase pressure inside the disc versus other postures. So folks that have disc problems, generally speaking, when you come in the room, they're not sitting on the chair. They're standing up in the office. They don't like to sit down.
Right.
So, well, it's a frustrating time then for us because there's not a lot we can put in there that's available. Right. Where do you think we're headed? Get out your crystal ball now, because you said in 2006 you would have thought we'd have a product by now. I did too. I keep pushing it out. Just give it 10 more years. Just give it 10 more years. So I keep pushing it out. But where do you think we're headed?
Yeah, it's a good question. And I think the answer partly involves, well, we're learning as we go along. Like, we started out with growth factors and that's not it. And then the fibrin sealant, and that didn't do it either. And now it's cell supplementation. And then is it going to be something else that maybe involves a gene therapy or a viral vector? There's some technology being looked at there. So I don't know. But fundamentally, it's got to be something that controls inflammation and helps restore or improve disc biomechanics. The Mesoblast data looks like the cells do something over and above the saline in their phase 2 trial. Their phase 3 data hasn't undergone peer review yet. The Vivex data uh, outperformed certain areas, the saline arm. Hopefully they can move forward with an additional trial. That's what the FDA is going to ask for. So we'll see. It could be some form of cell supplementation. Dysgenics is another one that's completed a phase 2 study. Those results are pending.
Yeah, so those results aren't out there. That's all I got for you, Mike. You got anything for me? You got any questions for me?
You mentioned intradiscal steroids, right?
Right.
How have they been helpful for folks? Like, do you you see a dark disc on MRI and inject some?
Right. Now they do best. They do best for when you see inflammation on MRI. So if they've got these modic 1 changes, they do very well, kind of like the Relievant folks. And so a lot of times I will do an intradiscal steroid, and if they get short-term relief, let's say between 3 months and 9 months, I might move on to Relievant. But they do generally get a therapeutic window. So instead of doing, let's calling it a provocative discogram, it's more of a therapeutic discogram. And then also acute herniations do real well. So anytime there's something that looks very inflammatory, the steroids definitely suppress the inflammation and help the pain considerably for a period of time. The problem is it doesn't restore the disc, it doesn't regenerate the disc, it doesn't change the biomechanics. And just like any other block we do, any other epidural steroid injection or facet injection, it's a temporary fix. Now, define temporary. Is temporary 9 months? Is it 2 weeks? But I do find that useful in my practice, especially because a lot of times, a lot of doctors won't even look at the disc as a source of pain because they don't have anything to offer them. So they've been through the litany of injections, and no one's ever really taken the time to study the disc or to pin the problem on the disc.
Yeah.
So it gives me an opportunity to treat something that hasn't been treated.
Yeah. Yeah, that's a great point. Honing in on a disc and suspecting it's the first step to treating it. So I'm just curious, you put dexamethasone in the disc, or?
I have moved to Dex. I used to use beta methazone and triamcinolone, but just to keep things simple, I just use Dex on all my injections now. It's just easier, and I haven't noticed a difference.
Yeah.
So DJ Kennedy's data basically is it's non-inferior, whatever that means. So it's just simpler to have one steroid.
Yeah. Yeah, well, it makes sense that a potent anti-inflammatory drug, corticosteroid, would alleviate certain patients' back pain when injected into the disc, because the disc probably hurt.
Especially when you see these modic changes, modic 1 changes in particular, and also acute herniations. I think they're really good for acute herniations. And a lot of times what you'll get is what I call a transdiscal epidural. So we've got interlaminar epidural, we've got transforaminal epidural. It's just another way of doing an epidural because that disc, that annular tear, that herniation, it hasn't healed yet. And so you're basically doing an inside out epidural.
Yeah. Yeah. Interesting. I hadn't thought about that.
All right. Well, that gets you out of here at 4:25. Michael, I appreciate you doing this. Keep up the great work. It's fun to have you on. And if there's ever something you want to talk about on Doc Talk Live, let me know. You got something to put out there. I'd love to have you. You're always welcome.
Thank you, Brad. I'd love to be back. This was fun.
And not only that, let me say this. If you ever want to just do your own Doc Talk Live on my platform, just let me know, and you can interview whoever you want to interview or talk to whoever you want. Doc Talk Live is not about Brad Goodman. It is not about, I don't even, I tell you this, I would rather do like cardiology and other top COVID. But you know, I interface with spine so much that I end up doing maybe 60%, 40% orthopedic type things. So
Yeah, it's natural.
anyway, it's great to see you.
Yep, you too. I'll keep that in mind, the invitation to do something on.
Yeah, it's always open.
Okay, good. Well,
Take
thank
care.
you again. You too. Bye.
See you later.